Approach, approach to ECGs: check age, gender, name, calibration 25 mm per second, 10 mm per millivolt, 1 mm equal to 40 milliseconds or zero point 0.1 millivolt. First of all, check for rhythm. P for every QRS and V. P positive in lead 1 and 2, 60 to 100 beats per minute. If the rhythm is irregular, then the rate is 300 divided by big squares RR only. Number of QRS in 10 seconds into 6 is the formula for irregular rhythm. 2 dots, 3 seconds. Number of QRS in 6 seconds into 10. Axis: QRS is positive in 1 and 2. Left axis deviation in fear MI, WPW, LV hypertrophy, left bundle branch block, left anterior fascicular block in left axis deviation. In right axis deviation, possibility of anterolateral MI, WPW, RV hypertrophy, right bundle branch block, left posterior fascicular block, dextrocardia, or normal variant of right axis deviation. Intervals: PR interval is 120 to 200 milliseconds, which is 3 to 5 small boxes. His PR interval AV block high PR interval AV block, low PR interval, short PR interval in WPW ectopic atrial pacemaker. QRS is usually normally less than 100 to 120 milliseconds, that is 2.5 to 3 small boxes. Wide QRS, right bundle branch block V1 to V1 to V2 RSR prime, lateral lead slurred S in right bundle branch block, while in left bundle branch block V5 or V6 will have small R big S, small Q big S. Lateral leads have small r, small s, small r prime. Ventricular pacemakers can cause wide QRS. Hyperkalemia, ICD, or pacemaker devices can also lead to wide QRS complex. QTC is usually less than half of the RR interval, or in men less than 420 or female less than 440 milliseconds. There is no safe number, but more than 500 QT, corrected QT interval is dangerous. Short QT is less than 300 to 360 milliseconds, that occurs in hypercalcemia. Long QT antis and hypos like antibiotics, antipsychotics, antidepressants, tricyclic antidepressants, antihistamines, antiarrhythmics, hypokalemia, magnesemia, congenital long QT. In MI, there is long QT and high intracranial pressure. QT can be prolonged. Hypertrophy: left atrial enlargement in lead 2 P wave more than 100 milliseconds, 2.5 small boxes, or V1. P wave is biphasic with P mitral morphology. In right atrial enlargement, P wave is more than 2.5 small boxes tall, that is P pulmonal. In LV hypertrophy, sum of R in V5 plus S in V1 more than 35 mm if above 40, more than 40 mm if fit, or 30 to 40, more than 45 mm if less than 30. Alternatively, R in V6 more than 26, R in 1 plus S in 3 more than 25 mm, R in AVL more than 11 mm. RV hypertrophy: R is bigger than S, R more than 7 mm in V1, R less than S in V5 or V6 with right axis deviation. Occurs in pulmonary hypertension, mitral stenosis, pulmonic stenosis. Differential diagnosis of positive R wave in V1 is RV hypertrophy, right bundle branch block, posterior MI, WPW, Duchenne muscle dystrophy, and wrong placement of leads. non-sinus tachycardia, narrow QRS, SVT, regular AVNRT, AVRT, atrial tachycardia, atrial flutter or junctional tachycardia, narrow QRS, SVT, irregular AFib, multifocal atrial tachycardia, atrial flutter with variable block, wide QRS, regular monomorphic VT, SVT with wide QRS complex can occur, irregular polymorphic VT and torsade.